Welcome back to H Hour. Before I roll into the usual intro, I just want to remind people that you can suggest guests for the podcast. The best way to do that is by going to the website, and there is a suggest a guest option in the menu on the website. The website is charliecharlie1.com, and you can go and suggest a guest in there. I'm always lining up guests. I like to schedule in as far ahead as I can. Predominantly the work of finding and scheduling the guests is done by me. My life is made a lot easier if I'm not out there searching, or if I'm not out there searching, a lot easier if good, interesting suggestions come to me from you, the listeners. You, the listeners, and you, the viewers, are the ones who enjoy this, and I want to know who you think I should have on to discuss. Particularly if, to topics we're going to be talking about today, some of the stuff we talk about, you may think, I don't know about that, or I've heard different, or I feel like someone else could add extra value to the topic. Suggest the guest away. It's no problem at all. So, charliecharlie1.com, go to suggest a guest, do it that way. Or if you don't want to do that and you're following HR on the socials, just drop me a message on the socials. The absolutely best way to make sure you get a guest suggestion in front of me is to become a patron. I get guest suggestions from the patrons all the time, and they have direct access to me, or I say direct access to me. They have the ability to message me in private closed forums, which is only for the patrons, and we occasionally have Zoom calls where we're on calls together, and sometimes with previous guests. So become a patron. Patronage costs as little as £3.50 a month. That money goes towards supporting the podcast, supporting what I do, and I appreciate that sentiment very, very much. And patrons are the I find them one of the best feedback groups I can use to help inform what I do going forward. And I say that because, patrons optionally subscribe to me, paid subscription to H Hour. They don't have to do that. They do that because they are emotionally invested somewhat before financially invested in the podcast. So that means that their opinions carry a lot of weight, and I take a lot of I pay a lot of heed to what they say, and they're a great group of people, and you can join that group too. If you are listening to this podcast and you're not aware that before this episode with Alastair, there's been an icebreaker with Alastair, which is about 20 minutes long, where I did a Q&A with Alastair, and the questions have been submitted by patrons ahead of the episode. They got wind that Alastair was coming on because I told them they get access to the guest list, and they submit questions for Alastair. So you can rewind back, listen to the icebreaker first, is my suggestion, 20 minutes, and then roll straight back into this podcast. Or you can totally ignore me and carry on watching or listening to this now. Either way you do it, you're going to enjoy it, but do consume both episodes. So without further ado, Alastair Santhouse, a real pleasure to have you on, and I'm very glad I could capture some of your precious time today. Thank you very much.
Oh, it's such a pleasure to be here. Thanks so much for asking me.
It's good. Well, it's a subject like psychology is a subject close to my heart from personal, my own individual experiences, and also people close to me with some of the topics in the book, but also I really enjoyed the book, and like I said to you, I've got about, full disclosure, I've got about half an hour left. I'm audible in the book. I've got about half an hour left. I've got through most of it. Now, you were saying on the icebreaker that one of the reasons you wrote the book was to try and, spur, I don't want to represent what you said, but you basically said to spur debate. You have an open debate about some of these topics that are being seen as controversial, or some of the, the scientific evidence and facts can be controversial to discuss, I think. I did not read the book like that. So the way I listened to the book, my thought on the way it was put together was that I thought this is a really good book because it is covering everything. So it is not straying away from talking about certain topics or in certain ways that would be deemed harmful or offensive because they may upset some people, or may people cause some minor emotional distress, shall we say. I read it as a really balanced, informative explanation from your point of view and description of, so many of these psychological conditions, diagnosis topics that are sort of mainstream now, or have been for a while, but everything from autism, ADHD to, narcissism, to schizophrenia, to depression, and all these things. Generally, I learned a lot from the book. So thank you very much for writing it. I'm sure other people have too. I highly recommend it. I do want to start with adult ADHD, if that's okay with you. And the reason I want to start with that is because there was a moment in your book and I thought, God damn it, I've been self-diagnosing. God damn it, I've been self-diagnosing, and I immediately knew that I had. And the reason being, right, and I think this is common, a lot of people, especially the ADHD label, right? So I have suspected for years now that I suffer from ADHD, right? Now, I was reading your chapter on this. I was thinking, maybe I'm not. You were talking about, I realize I'm talking a lot here. Sure. I'm just going to hand over to you in a minute because I know you can talk a lot on the subject. Long story short, through reading the book, I thought it totally convinced me otherwise, that I am not suffering from adult ADHD, that my symptoms that led me to think about this, I've had many years now of difficulty in focus, difficulty in concentration, real poor short-term memory. Right? So short-term memory loss, I'd say. Well, yeah, short-term memory, really poor. In the past, it hasn't been like that. In the past, my short-term memory has been incredible. And it was not average, really, really good. And I never used to have a problem with focus. I never used to have a problem with concentration for any length of time. It got that bad at one point. I couldn't read a few lines in a book, for example. I can now. But what I realized in reading your chapter is that I can change all those symptoms immediately. I know how to improve my concentration, my focus, and my short-term memory. I know how to do it. And because everything that influences it, I've come to learn, is within my control. And when reading the book, I thought, well, if it's in my control, I know how to change it because I've done it before, then this isn't a condition I've got. As in, it's not ADHD I've got. I can change that myself by changing these external factors.
Right.
And some of those changes would be drastic, but some of them are really small. Like, I'll give you a really simple example, and I think one that a lot of people overlook. And they're going to go, oh God, roll their eyes when they listen to me say this. My mobile phone. People are affected by mobile phones in different ways, I think. I am really affected by it. The more time in the day I spend on my mobile phone, or the more I'm thinking in the background when I'm not on it, and it occupies my mind in the background, and it really influences my focus. My most productive days are when I say, I wake up in the morning, I do whatever I feel I need to do on the phone. 9 o'clock, I put my phone down, I tell my girlfriend, you're not going to be able to get a hold of me for the next few hours. I'm going to do some focus time. My phone goes to the side until lunchtime. Out of the way. My God. My ability to focus and concentrate on a single task goes through the roof. I will be on it for 3 hours, at least, without break, maybe a coffee. If my phone is next to me, I cannot do that. I cannot do it. I cannot concentrate on what I'm doing. It is there, it's in sight, and I feel like I'm on it. I've not set that boundary to myself. That's one little example. There's a bunch of other stuff that influence it. The whole point in this is, I absolutely thought I had ADHD until I read your book. And now I know I haven't. I know. Now that is just me, a unique case. It's very clear cut. And I'm very lucky that I have the ability to be quite sensitive to the way that my brain works, my emotional state, things that impact me in that way psychologically because of past experiences, which I'd rather have not have had. Other people aren't like that. So that's a thank you, actually. It's a thank you. But it's a little adult ADHD anecdote. Could you explain to me any concerns you have with misdiagnosis of adult ADHD? And I think you also questioned whether adult ADHD is even a thing.
Oh, well, yeah. So you've said a lot of things. By the way,
sorry.
It's good. It's good. But thank you for, I'm glad that I managed to undiagnose you from afar. But I think, first of all, we know that ADHD is a neurodevelopmental disorder. And by the way, and just for the avoidance of any doubt, of course, I believe in the diagnosis itself. And we know that some childhood ADHD will persist into adulthood.
Can you, define what you mean by neurodevelopmental disorder?
So I think these are just as the brain develops, some people's develop when
you're young.
When you're young. And of course that, and what often isn't really appreciated is that a lot of people with ADHD in childhood don't have that diagnosis in adulthood. Their brain has developed sufficiently or in that particular way, so they wouldn't classify themselves as having or meeting the criteria for symptoms. But some do persist. There is several percent, and it depends what studies you read, but there is a persistent rate into adulthood. So those people, you would say, that had childhood ADHD and now they've got adult ADHD because it never went away really, and they still need treatment.
15%, something like that?
It depends. I mean, I've read different numbers, but between 5 and 15, and some persist, but in a slightly milder form where they wouldn't have the full set of symptoms. So I wouldn't suggest that it just goes away in adulthood, but many of them do, some don't. But the question that I think comes up more is, what about adult ADHD that's just made as a diagnosis for the very first time in adulthood? How many of those are people that we just missed in childhood, where we should have picked them up and we just didn't? I have no doubt that there are some of those people. In fact, I know some of those people, and it's clear that that's what they did have. And it retrospectively explains a lot about their lives. But there are a number who present now for the first time thinking that they have adult ADHD, and when you really get down to it, they don't. And I think the problem, I mean, I mentioned earlier on, one study looked back at people diagnosed in adulthood or people coming forward in adulthood for the first time with potential adult ADHD diagnoses and found that they didn't have, in 90% of cases, any neurodevelopmental problems as children. If it's a neurodevelopmental disorder, then the question arises, how can you be diagnosed with a neurodevelopmental disorder in adulthood if you didn't have one in childhood? I don't think you can. And it's not to say that people don't have something. I mean, people don't come and sit in front of a psychiatrist or a doctor for want of something better to do, but they believe that there is something wrong. The problem is that now I believe that one paper puts it says that the diagnosis of adult ADHD, the criteria are so broad that they don't really differentiate very well between ADHD and normal variation. And a lot of the symptoms are common and relatable. So, for example...
Sorry, just quickly. By normal variation, you mean normal variation in psychological
I would say,
behavior.
What is normal for anyone without a diagnosis to experience. So we all experience at different times lots of different emotions, feelings. Inattention might be something that people associate with ADHD, but it is quite common in the population, and it's very common in all sorts of mental health problems. So,
and attention span is getting less in general, right?
Well, again, I mean, that's sort of people worry about that, and I don't know the evidence on it. We've worried forever about, there was a time when people worried about newspapers and tabloid newspapers reducing attention span, and then television and social media. I think we've always worried that we're sort of devolving, whatever the opposite of evolution is, as human beings, but I'm not sure. But I think that a lot of the symptoms, like not being able to focus in a sustained way on tasks or not wanting to complete a task, or impatience, or cutting across people and when they're talking, or interrupting people, all of those are pretty, broadly common things to do. They're also scoreable on a lot of the ADHD questionnaires. So you get into a position where I think it can be very difficult to make that differentiation. And it's important because if you're saying someone's got adult ADHD, well, for a start, you're labeling them with something. And secondly, you might be starting them down a treatment pathway that really isn't appropriate for them. A lot of people are going to all sorts of different clinics, and understandably, because the NHS is, there's long waiting lists now for these kinds of assessments, and often a label is being endorsed, and I think it can potentially do harm to people. We talk a lot about the harms of underdiagnosis, and lots of campaigns are about awareness raising and is there underdiagnosis. But I think similarly there there is harms in overdiagnosis to the individuals, to society, and we need to think more carefully and ask the question, what is adult ADHD, and are we getting this balance right?
What about though? But how do you balance? Sort of communicating the message and trying to inform, Joe Public, from Joe Public to clinicians and people who can provide a diagnosis on the dangers of overdiagnosis? How do you balance that with stigmatizing, or again stigmatizing certain diagnoses and labels like autism, like ADHD? And I'll give you an example on that. One of the things I hear, I want to say commonly, but I've heard it at least 3 times over the last few years, is that everyone's a little bit autistic. Everyone's a bit autistic.
Yeah.
And I think that is one of the examples of an impact of overdiagnosis, in that the reality of, autism is being watered down.
Yeah.
So someone with severe autism, that sentence is quite dismissive to someone who their life is pretty severely impacted by it.
Well, I've heard this before, and I know people with children with significant diagnoses, patients who've told me, and they feel that they're getting squeezed out of the conversation. And I think part of the problem, from my perspective, that things are being overdiagnosed, I think part of the problem, we talked about the harms to the individual of a label, and people limit themselves in what they can do because they've now labeled as having a particular disorder. But I think part of it is about whether we lose public trust in our ability to make accurate diagnoses in people. I think there is an issue to be discussed. I mean, we've always had to tread that line between stigma and diagnosis, and I don't think for a second there was a golden age of psychiatry we should go back to, that where we got that balance right. Certainly when I was sort of training in the 80s, stigma was a real problem. And people that we could and should have helped didn't come forward. Now we need to ask where is that line? Where is the balance? I mean, for things like, I told you about adult ADHD and, the care we need to make in having the diagnosis. But in childhood, we know from studies that one way to be diagnosed with ADHD in childhood is to be born in August. That there's an excess of August birthdays in children who are young in their school year, because often immaturity is being...
Oh, you mentioned this in the book, actually.
Yeah.
Yes. Go on.
So immaturity is being conceptualized now in let's say, a rush to diagnosis or to label a particular behavior and pathologize it. And I worry about that. Diagnoses are difficult, time-consuming, and as I said before, it wasn't me that came up with this, but someone said they should be written in pencil, and I like that. As we should be far more circumspect about making these diagnoses, and certainly for a diagnosis that's becoming increasingly common and explaining a lot, I think we need to be a little careful about whether this is actually correct.
Let's talk more about that, actually. I'm going to caveat this with, there's a person who's very, very close to me, and they were diagnosed with autism and ADHD. And having since read your book, actually, I feel very fortunate in that I was concerned about a misdiagnosis. I felt like things were being overdiagnosed before that, and I was certainly less informed than I am now, just generally about this subject. I was a little bit more informed than people in general through the benefits of the podcast and the kind of people I've spoken to, like yourself. But I was concerned about a misdiagnosis beforehand. Now, in hindsight, I feel after the diagnosis and I found out how the analysis assessment of this person was done, it was much more in depth than what I expected. I had the benefit of Yeah, of knowing sort of some of the details of how it was done, and the person had the benefit of being able to have a private analysis through a very trustworthy and prestigious clinic. And it took months and months and months, and multiple ways of getting information about the person to make an assessment. Now, and which got me to the point where I thought, okay, I'm not concerned here that this is a misdiagnosis, and I'm absolutely not. But a point you made in the book is that most people don't have the opportunity. I think they don't have the opportunity to go and be able to select based on quality as opposed to cost. And also, and when you've got that case, also it's very hard to try and judge the quality or the effort or the ability of the clinician to put the amount of time that's required into a diagnosis of these kind of things, because to your point in the book, you need to contextualize these against the backdrop of the person's individual circumstance,
Exactly
their
right.
life, all these other factors, not just in interview, tick box, in interview, tick a few boxes, score a few things 1 to 5, and then out the door after an hour consultation, and you've got a diagnosis.
Yeah.
Huge dangerous, right? Would that be fair to say?
I think that's exactly fair. I mean, I think sometimes we mistake the questionnaire tick box for the diagnosis itself. It's, as I said, relatively easy to score above threshold on a lot of diagnostic scales, but actually has nothing to do with whether someone's got that diagnosis. I mean, just as a slightly banal but I suppose illustrative case that's not about psychiatry, someone I know had, I can't remember what it was, it might have been a headache or something like that, and called up NHS 111 for advice. And they go through a tick box of questions and they ask about neck pain. And this person said, they slept badly the night before. So they said yes to neck pain. And the next thing is an ambulance is called because it's flagged up as meningitis. And of course,
No, it's
on
not
a
funny.
piece of paper, it looks like it could be because they've got a headache and neck pain, and maybe they've got a bit of a fever, or maybe they haven't. And the next thing is, and you can do that as well with a lot of psychiatric sort of questionnaires, which is, unless you know what you're doing and what you're looking for, and as you said, contextualize the diagnosis and really understand why and how and what the symptoms mean, and again, what way they're impacting their life. We have, all of us, sort of a range of normal human emotions. Sometimes they tip off into something diagnosable and treatable. And, we need to consider the extent to which they're actually having a real world impact. I think, there is a question about whether we should be diagnosing people. I mean, a genuine question about whether we should be diagnosing people where they are functioning completely normally in their lives. Now, you might say they need some help, but does a psychiatric label, is that the thing that's going to help them? I come back to it a lot of times. People are often living really difficult lives of distress, of insecurities, financial, social, job, and all of that. The extent to which putting a diagnostic label on that is really the question that I've been struggling with. And I think we've been too ready to diagnose people.
God, that's a tough one, though. So, okay, it's a tough one, though. So, because if, let's say you were to put that hard and fast rule in, okay, well, if they're functioning normally, then is their mental state that serious, right? For a diagnosis. Yes. But I know people, and you absolutely probably certainly know people who have been functioning perfectly, perceived to be functioning perfectly normally from the outside looking in, but internally within their heads, they have been in complete despair. Sure. You wouldn't know any different.
Okay, I take that point, and perhaps that's overstating what I said. I mean, clearly, some people are, if they're able to go through the motions, the extent to which that is, I don't think you would say, well, they don't need help just because they can keep the show on the road. And I think that comes to the heart of the problem, which is where do you define that boundary and how do you know? I mean, if you look at a diagnosis like depression, for example, it's a range of symptoms from mild to moderate to severe. And some people have really extremely severe symptoms. At what point do you draw that line and say that this is a diagnosis? I'm not saying people don't need help. People do need help. But the question about a diagnosis is an interesting one. And I don't know if we've quite got that balance right. If you're at the milder end of the spectrum of depression, is conceptualizing it as depression a helpful thing to do? As I mentioned before, it might be that there is a lot of environmental factors of, as I said, housing insecurity, relationship difficulties, job insecurity, financial worries, loneliness, all of those things that could be really what this is about. And of course, people experiencing that feel sad and uncertain and not sure, where they're going, lacking in motivation. But to distill that down into depression and say, well, here's a medication that I think you should take, sort of ignores a lot of the sort of wider contextual problems that really is what they need help with, of social contact, of interaction, of consideration of things that may be out of your control, may be a government thing about housing and similar. And so my worry is that distilling things down too quickly into a diagnostic label might not allow people to get the help that they really do need.
Mm-hmm. I think in fact, no, there was so we were talking just now, there was something that surprised me, which I learned recently. I don't think you mentioned it in the book, but I learned recently, and this is on the subject of pathologizing sort of normal behavior, suicidal ideation. That is something I didn't realize until relatively recently. It's pretty common.
Yeah.
So am I correct in saying most people will have some form of suicidal thoughts regularly? Without a concern for it?
I wouldn't say most, but I would say it's probably, I don't know the exact figures, but it's probably commoner than is generally believed. And then there's, of course, there's a range of from sort of passive kind of, it would be easier if I didn't wake up in the morning, through to a sort of a certain, like a recklessness. People stop paying attention to their health and they might not pay attention properly when they're crossing the road, sort of letting fate decide what happens, right through to people with active sort of thoughts. And so it depends what's meant by ideation. So there's a range, in other words, of what goes through people's mind from life is too much to bear, but never an intent, to, through this sort of range of thinking, well, I wish the end would come sooner, right, up to people with intent.
Okay. When I was reading the book, you had a great quote in there. And I'd like you to expand on, we've touched on it a little bit so far, but I'd like you to expand on exactly what you mean by this, if that's all right. And the quote was, you tell me what diseases you have, and I'll tell you what decade you're in. Now, I read that, I thought, I got to remember that quote. That is superb. You coined that phrase, right?
Yeah, well, yeah. I mean,
okay.
Yeah.
It's great. Can you explain it, please?
Well, I was trying to get across that in medicine and psychiatry, things evolve over time. I'm sure, no one's really going to their doctor with silicosis very often anymore, asbestosis, or, industrial diseases from the 19th century. When I was growing up, Rubik's wrist was quite a thing. From people doing Rubik's cubes too quickly, they'd sort of get a tendon strain in their wrist, or from doing it. And you think, well, smoking-related diseases might sort of define a certain era of our time, and you would have maybe with Ozempic and all the other medications, maybe obesity-related illnesses will define this particular time as, So I think each era, HIV was very much of its time. It's not a problem now, but it's not the big sort of story that it was in the 80s and 90s. And so I think I think that illnesses seem to define a particular era. And I was thinking, well, it's the same in general medicine, but it's also true of psychiatry as well. The way illnesses seem to dominate, become very prominent in the foreground, tells us something about where we are as a society.
Is that true of, so if I was to, when I'm thinking about that, I would say that could be the case, sounds like it's the case for something like gender identity. As an example of, like, we didn't have, so beyond 5 years and beyond, it was much less the case that you would find people feeling like they were born in the wrong body, for example. And it feels like that the curve is dying off now. It's sort of the other end of that histogram, if you like, it's dying off now, that era. Is that an example, would you say?
It's difficult. I mean, it's not something that I've seen a huge amount of. I have seen people with gender identity disorders, and very often it's sort of a bit beside the point. I think there's always been a base rate of people with gender identity problems. There's clearly been very newsworthy in the last few years, and I think it's because it's become about competing rights, which always seems unresolvable, sort of right to spaces and who's got the right to be where. And I think that those sort of oppositional arguments become very newsworthy. But I would
especially
say,
when they're connected to politics, right?
Yes, exactly. And I think as well, autism and ADHD are diagnoses that we're hearing a lot more of now than we used to. We hear a lot about trauma that we, again, didn't really used to. The diagnoses, over time, what diagnoses are sort of, if you like, in the common conversations, they do seem to change. And I think that's, the question is, are we evolving to a more enlightened way of understanding psychiatry, or are we, where are we now? Have we got the balance right? Again, I come back to this.
Yeah, I mean, on the subject of, on the gender identity thing, I think, but personally speaking, I think mostly likely that wave is partly due to political flag waving, in-group, out-group behaviour, unfortunately to the detriment of some people who, got caught up in that. And linked in with that would be a social contagion of some sort, I think. Similar to the things we've seen in the past, in the same way with gender or sexuality orientated behaviour, right? 'Cause that's what predominantly what it is, behaviour. Ignore the having operations and starting to physically change things, but the behaviour and the behaviours that you use of it. I think, am I right? I'm pretty sure I'm right in saying, like, late 80s, early 90s there was a massive increase in people identifying as homosexual, I think, if I remember correctly, and that kind of died off. Obviously, there's a base rate there, but on the subject of, coming on back on the subject of autism and ADHD, so with those increased rates of diagnosis, is that not predominantly down to the two things, that we are getting better at identifying and assessing people and being able to identify people who are autistic and ADHD, whereas previously we just weren't that good at it, for whatever reason, and also that people are more willing to see a GP about it.
Okay, so just a few things about that. I mean, just coming back to the homosexuality thing briefly.
We are dotting around your side because my brain's all over the place.
But I think that probably, if I'm not sure whether it was or wasn't an increase, but certainly
I might be talking nonsense.
the stigma of it was certainly from the 80s and 90s was starting to lessen. I mean, a lot of your listeners might not know that homosexuality was included under the mental health disorders in the classification systems till about 1980 or thereabouts. And again, that's why I say there was no golden age of psychiatry. And I think people, it was clearly offensive and very stigmatizing. So I think that probably part of that was people who felt at least a bit more comfortable about being, and saying who they were. As far as the autism ADHD, I'm sure that some of the increase is about people being recognized now who weren't before. I do agree with that. I think that there must surely have been people missed, and we have got better at that. But what we see is a rate of autism that's gone, I came across a textbook, or it's like a handbook, but anyways, it was like written about 94, 95, and the section on autism said it's a rare disorder, 2 in 10,000, it said, with 50% would develop useful speech and 15% of people would lead an independent life. So that was how autism was thought of.
2 in 10,000.
2 in 10,000. So now...
It's not that now.
It's not that now. I mean, it's about 1 in 30 is...
1 in 30?
1 in 30 is roughly where the figures are at the moment.
Goodness me.
So there's been a very substantial increase. And I don't think all of that can be explained by increased recognition. I think there are... I think the way guidelines are written allow for more sort of subtle kind of difficulties of social interactions and similar. And they are not as sort of tightly written. You could say, well, again, you could argue, well, that's a good thing because we're picking up people with lots of different problems and, we're trying to help them. But I'm not sure, again, whether we always do help them. A diagnosis has to, I think, carry some meaning in not just to... I think when you diagnose people, you can start to limit them as well. A lot of when we diagnose people, we assume that it's always a good thing putting a diagnostic label on. But I think it can be quite limiting. I think they can be quite sticky labels. And I know certain of my colleagues have said that people have come to them to be asked to be undiagnosed, to have their label of autism removed. They feel somehow that it's constrained them as much as it's explained anything for them.
Can you give me some examples of like a person who would benefit less from having the diagnosis than not having it?
Well, I mean, I think if you now have a diagnostic label put on you, I think it can alter your self-perception of what you think you're capable of doing, of how you interact with other people. I mean, if it's a well-made diagnosis, good, you should have that. It may be extremely helpful for you and for other people around you to understand your interactions with them. But where that diagnosis is a little bit looser, it can start to affect how you see yourself, how other people see you, what you think you can do or accomplish. And there, I think it can start to be limiting. In the world of ADHD, we know that the number of medications prescribed has increased very markedly. And I think there was an article in the Financial Times that said that it had, I think this was for adults, increased by far more in the 20% of the wealthiest areas compared with the 20% of the poorest areas. In other words, there's a very uneven distribution of where and how people are diagnosed, both within countries and worldwide. A diagnosis,
so the rate of diagnosis has gone up in richer places as opposed to poorer places?
Yes, or it seems to be the case that prescriptions have.
Prescriptions, okay.
Which presumably reflects diagnosis rates. But for ADHD, you would expect, if we were uncovering diagnoses, you would expect it to increase and then plateau out. But we seem to be seeing a very steady increase that really isn't showing that many signs of plateauing. where we're seeing lots of uneven geographical distributions between countries, between different areas in the same country. And you ask yourself, well, how plausible that...
So different rates?
So different rates. So it's much higher in the USA than it would be in Japan or France or whatever. So, you ask yourself the question, well, what's happening? Which of these is correct? I think that, if we're describing an illness called ADHD, there needs to be some sort of consensus, and I think you would expect there to be a sort of, it reaches a stable rate.
You would have geographical differences, though.
Well, in as much as if you're making a diagnosis,
well, you do have geographic. Yeah, go on.
In ADHD I guess the question is there any reason why Americans would be more prone to it than, say, Japanese or?
I can hypothesize.
Okay,
diet, lifestyle.
But if we're saying it's a neurodevelopmental disorder,
situation,
well, it might be, or it might be the environment. But if we're saying it's a neurodevelopmental disorder, these things like, autism should be quite a highly genetic sort of disorder, and we should be seeing relatively stable rates.
Okay, yeah, I see what you're saying.
And we're not seeing that. We're seeing a lot of variation, and I think that's and I think that needs to be explained. And if the explanation isn't, I don't know how you explain it if you're saying this is just uncovering.
Could we be dealing with, so on the subject of ADHD and autism, these conditions that seem to be on the rise, could it be that it is ADHD? Could it be that there are misdiagnoses, but it is of a new condition that has been identified and is down to the impact of this immersion, this age of information and constant exposure to information, internet, apps, social media, which no one can get away from these days. Very few people can get away from. And that is having a serious psychological impact across the board, which could be responsible for what we are diagnosing as adult ADHD, but actually is not. It's something else.
Yeah, I think that's an interesting hypothesis. And the question is there something specific about modern life now that could be that? As you said, social media and this sort of 24-hour news cycle and this constant pace of life, might be. It's an interesting hypothesis. Would you call it a diagnosis? I don't really know. We see lots of these new diagnoses coming up, mobile, smartphone addiction and similar. And the question is, how valid are these diagnoses? I don't know. In the 1900s, there was a diagnosis.
Smartphone addiction, sorry to interrupt.
Yeah.
Smartphone addiction is a diagnosis these days.
I'm not sure if it made it into the diagnostic classifications. I was looking at one paper that suggested that 30% of people had problematic smartphone use. And I'm thinking,
That's a behavior. Yeah,
what does that mean? And does it mean that we're addicted in some way? What does it mean to be problematic? I use my phone to check my work emails, to try and learn a language, to, watch TV. I'm on my phone a lot. Am I addicted to it? I don't think that's a helpful framing of it. And if it's 30%, then I worry that a lot of these new diagnoses, the first question people ask is, how common is it? Not, is this a valid diagnosis to start with? Is smartphone addiction a valid diagnosis? Is it in any meaningful way an addiction?
So is what you're saying there, if everyone is exhibiting the same behavior, then is it a problem? Or is it just the way we behave now? Is that
well, I guess you would say, well, let's suppose, and we follow that through, that there are a certain number of, we're making this sort of diagnosis of problematic smartphone use, or I don't know, call it addiction. I'm not sure what you'd say. The question is, well, what does that mean? Does it mean that we ought to be offering treatment to 30% of the population? And if it does, where's that coming from? And if it doesn't, where is the value of this as a diagnosis? But it's sort of appeared, and you see it from time to time. And again, I'm trying to make sense of what it actually means. I know that during any 2-minute lull in a conversation, the first thing I do is reach for my phone. It's sort of like a reflex habit. I'm not sure, again, what that's a sign of. I'm not even sure I can remember what I used to do. And I sort of sit there with my arms folded and, so
the reason I mentioned earlier that I suggested that hypothesis that maybe we're seeing a new condition, which is because of this. Now, one of the reasons I've mentioned that, I thought of that a lot, is because of exactly what you just talked about. The amount of time we used to have available to ourselves to do nothing but introspection. You sit at a bus stop. You would sit at a bus stop. You wouldn't do, unless you stood there with someone or sat there with someone, you'd be just thinking. Your brain is just plodding along, just thinking about whatever it thinks about, what just happened, what you're going to do, what you think, why you're thinking what you think, whatever, daydreaming. No one thinks nothing, and all that time for everyone is gone because you've got this thing in your pocket that occupies your brain. All of a sudden you're looking at other stuff and your brain doesn't have time to do this processing. The only time it gets to do that is when you sleep now. Very few people have that opportunity, and I think it's a massive impact.
Yeah.
There is a definite, going back to earlier when I said, my adult ADHD self-diagnosis or suspected self-diagnosis was nonsense, is also part, when I read that, I reminded myself that I know there is a marked difference in the way my brain is. Literally, the way I feel changes from the moment I have that phone in my hand. The way I feel changes. I feel less, I don't want to say happy. I feel like burdened. Really, it's hard to explain the feeling when it's in my hand, when it's not. And that's partly because of that. I know partly that is because of a conscious thing. I think I don't need to be on this. I could be doing other things in my mind, and I think most people don't realize that. I do think it's going to be interesting to see the rates of things like ADHD and autism and other things in the generation below us when they're adults, and what their mental condition is going to be like. And I say, and it interests me because I got two, like you actually, we've got similarly aged kids. My kids, I used to be really concerned about the impact of phone use on them, and they got phones younger than what I would have wished, but it's just the way things panned out.
Yeah.
And I was thinking, God, this is going to be a nightmare. Like if I struggle to control, I can't have the phone in my bedroom. The phone has to be outside the room. Otherwise I'll wake up in the morning, I'll be straight on the phone. I cannot control myself out of the room and fine. It's terrible. It's like, it's embarrassing to have to do that. But I like that I do that to stay outside the room. At least I got that self-control. But they don't seem to have that. Like my youngest can be on her phone and go, all right, I'm going to go to sleep and switch the phone off and put it down. It's supposed to be on through all hours of the night. My eldest, I'm not sure. I don't know what a habit is with it, right?
Yeah.
But they seem to be able to control it much better because they grew up with it.
Yeah, I think so.
Which leads me to think maybe that we're the afflicted ones.
Possibly.
We've had it hard.
Yeah, no, I know what you mean.
I was very different pre-2006, 2007, before social media. Very different. I behaved very differently to what I do now in a lot of ways. You know what I mean?
Yeah.
It just kind of gives me hope.
I think so. I mean, I think I realized very quickly that it was, it's terrible, but it was almost unpoliceable, the mobile phone thing. Once it's very, very hard. But I think they've all worked out a way of switching their phones off, putting them down, leaving them as well. I don't know if that extends throughout the population, but as you say, maybe it does, and maybe there's hope there that people just work out a way of dealing with whatever they've got in society at that particular time.
Where were we? Okay. So what about, I think you were talking about in the book, masking. And if I recall correctly, you made a point in there, is that how do you define masking? Right. And the point you're making is that everyone does some level of behaving in a different way socially than they would if they were on their own. Like,
Yes.
they're not always behaving in the most open and honest way that they would intend to, or based on what they're thinking, because that would be socially unacceptable in a lot of ways.
Yes, exactly.
You know?
Exactly.
Is that fair to say? Can you explain it? Because I hadn't heard that before. I just thought, okay, yeah, masking, especially where autism is concerned, makes total sense. And girls more predominantly are prone to masking. But in fact, I'm going to stop talking. Can you explain what you meant?
Well, I mean, I think the term masking is literally sort of trying to mask your symptoms and to present a social face to the world that's far more acceptable. And
which is not abnormal.
Well, I mean, that was my question, which is, how do I understand the difference between that and what is commonly done, amongst people? We have our sort of inner kind of thoughts and feelings about, let's say, interactions, and we're socialized to mask them very often because we know that that's not how you should behave in public. And so I was just trying to understand what that term means and how sort of diagnostically secure it is. I know a lot of people particularly women, have said that they are underdiagnosed with autism and ADHD because they've been more successful at masking or concealing their symptoms, so they never got the help that they needed. And it was, so that was really where that question came from.
So on that, I mean, it leads me to think of it in a different way. You think about autism, you think, I know, one of the things that you can think is, okay, someone who's autistic, severely autistic, doesn't understand, has difficulty with social interactions, maybe doesn't understand very well what is socially acceptable behavior or how to interact socially with someone else. And the way you talk about masking there, and when I read it in the book, you could almost say that, okay, well, masking is a good indication that they understand social expectations and interactions, which would be counterintuitive to an autist or diagnosis of autism. Would that?
Yeah, I mean, I think so. I think it's a difficult one because
I don't know. I'm just asking
I think there's a discussion to be had, and I really don't want to sort of cause offence but I think that there is a question to discuss, which is, what does that mean? If someone is able to mask their symptoms, they don't present in the way that these descriptions of the diagnoses are written. Do they have that same diagnosis? The diagnosis was described in a particular way. If someone presents in a different way and says, because I'm masking my symptoms, is that the same diagnosis? Is it a diagnosis at all? Is it a different diagnosis? How are we meant to understand that? And I'm not sure, but I sort of think that there are certain things that must be very difficult to mask, like overactivity, or that is often a hallmark of ADHD. How is that masked, and what does that mean to mask it? So I mean, I think that was really where that discussion came from.
Okay, yeah, makes sense. I mean, the overactivity would be impossible to mask, wouldn't it? Again, I mean, on that masking and behaving in a social different ways, it's one of those it's very subjective to trying to assess, isn't it? Understand. Yeah. That's the problem with this, right? But a lot of the things that someone like yourself would be dealing with in terms of understanding from a patient, or someone who comes to you and thinks they're should be a patient, is that their experiences and understanding of what they're experiencing are very subjective. And the levels to which they understand it, or the severity of it, is based on their own experience and not the Joe public, right?
Yeah, I mean, I think a lot of time, particularly with those kind of diagnoses, people are trying to make sense of their lives, trying to make sense of their experience in life and wonder if a diagnosis might explain it. And then the question is that diagnosis accurate? Does it explain? Is it a helpful thing? You know, or is this a normal variation? And you can tell them, look, no diagnosis. And it's something that I've really noticed. You know, if you go to the doctor and you have a set of symptoms, and the doctor says, "Oh, don't worry, they don't amount to very much diagnostically," you'd be really relieved. But I've had more than one consultation, many consultations perhaps, where someone's come along with a diagnosis that they believe that they've had. And when I've said that they don't have it, it's not always been met with relief. But it's, well, this is what I do believe I have, and I'm not sure I believe you. And sometimes that's a difficult conversation to have, because you're taking something away from a diagnosis that they think explains things. Maybe they've joined a group of like-situated people, and it's, you know, it doesn't go like a normal consultation where someone is relieved to be told that they don't have a particular diagnosis.
I know what you mean. Yeah, getting caught up in a social group with that kind of thinking, where it is you're more part of you're a more highly valued part of the group if you've got the same X, Y, or Z thing that they have. From being a member of the ex-military. I was in the Paris too. Cool. Oh, you've also got a diagnosis of pick the thing, you know, which is probably one of the things that leads people to go and get a second or third diagnosis. And that availability, that ability to go and do that, accessibility of, I'm going to go get another diagnosis, but I'm going to keep going and getting assessed by different people until I get the answer I want.
Yeah, I mean, that does happen, and I'm sure it happens. And often you will find someone to endorse a diagnosis you want. Yeah, I mean, that's not uncommon.
Do you deal much with? Have you dealt much with PTSD?
Yeah, I mean, PTSD is not uncommon, and I certainly see it from time to time.
Because trauma is another thing that I think is getting watered down in the meaning of trauma.
Yeah,
and people looking for a diagnosis of PTSD from things that are normal experiences.
Yeah, I certainly think that as well. I mean, I think there's when trauma as a sort of psychiatric label wasn't really around until the last 100 years or so. I mean, if you'd said to someone in Victorian England, you'd been traumatized, they wouldn't know what you were talking about. I think maybe you'd been shot or stabbed or something, but they certainly wouldn't think that something mentally had happened to you. PTSD was really first introduced into the psychiatric classifications, I think it was about 1980 after the Vietnam War, as a diagnosis.
Okay.
And it came with a very specific set of sort of conditions, if you like, that the trauma had to be exceptional, out of the range of normal human experience, something really, threatening and pretty catastrophic. You know, we talked about wars and hostage taking and natural disasters, earthquakes and similar. It wasn't really meant to describe the more sort of, let's say, everyday, which are obviously distressing. And again, I've come back to this so many times, but just in case people are worried, that I am sympathetic to people's suffering. I do truly get that. And I do believe in psychiatry and psychiatric diagnoses. But the question is, how helpful is it to characterize some of this in terms of PTSD, where for events that really don't carry that same amount of threat? And I've seen people who've been told by a therapist that they were traumatized, and from maybe something that happened in the past, and the patient had never considered that before. And now they feel that there's something that's happened to them that they are no longer really able to control, that they need professional help with, that it's not. And it brought to mind an experiment which I wrote about in the book, which is how sort of language and labels matter. There was that, I think it's quite famous, it was done in the 70s, an experiment where people watch videos of a car accident. And so these cars hit each other, and students were asked to estimate how fast the cars were going. And they were given a different cue. So how fast was the car going when it hit the other car or collided?
So different students are getting different cues.
Correct.
Okay.
So some would say, how fast would you estimate when it hit the other car? Some other students when it collided or bumped into. And some were given the cue smashed. How fast it was going when it smashed into the other car. And the people that were given the cue about smashed remembered the car as going much faster. They estimated much higher speeds than the people with hit or bumped or collided with or whatever. And a week later, they asked these students about the scene, and they asked them if they remembered any broken glass or anything. And the students that were given the cue collided with, or hit or bumped didn't, but smashed into or smashed it, they remembered seeing broken glass at the scene, and there wasn't any. And it brought to my mind that how we talk about things might influence how we remember them and how we feel about them. In other words, it's not a benign thing. It might feel like a sympathetic thing to do to tell someone they were traumatized, but unless it's sort of an accurately made diagnosis, it might actually be quite unhelpful. Now, I understand that there's like these small t traumas that aren't meant to describe, events and similar. But I think as a PTSD label, I do see that. And the first question I ask myself is, well, what was the trauma? If it's, and I think it's an important question to address right before you get onto the symptoms.
But is what caused the trauma irrelevant is what caused the event that has been called the trauma irrelevant if that event had a severe psychological impact on the person?
Well, it depends. It depends what then. So let's say an unexpected bereavement.
Okay. Which is normal.
Which might be, someone might say it was very traumatic, and they might have a number of symptoms that come from that. Now, and let's say 2 years later, they're still suffering with that. You might say that they've become depressed or that something else happened, but the fact that there was something that they've referred to as a trauma doesn't turn into PTSD. It also is the case that they're still suffering with something that they need help with, and you need to figure out what that is. But the question is whether what someone refers to as trauma and what might have a meaning to a psychiatrist as trauma, are they the same thing?
I suppose sometimes if someone has been severely emotionally impacted by the loss, I mean, in fact, there's a small percentage of deaths which are expected, right? Relatively speaking, most are unexpected, I'd argue. But though, so if you've been severely emotionally impacted by the loss of someone, probably, most of the time there, you're dealing with something like loneliness or, loss of a companion, the loss of a loved one, loss of a confidant, which could, impact you severely emotionally, but it's not post-traumatic stress.
No, I mean, that's the point. It's
post-traumatic,
yes,
and it's stressful.
Yes, yeah, exactly. And a lot of things, I would say, come under that label, where someone might refer to an event as traumatic and they might be suffering something as a consequence, but the label of PTSD is meant to describe something a bit different. Interesting, on that bereavement point, there was in the DSM, the US classification, there was something called the bereavement exclusion for depression, which is that you couldn't diagnose depression in the aftermath of a bereavement over the following months. DSM removed that so that you could diagnose someone as depression in that sort of bereavement phase. And it met with a lot of, it was one of those changes to that classification system that got people really exercised, because I think what they saw was that bereavement was just part of, and the pain that followed it was part of what it was to be human. And they didn't really like the sort of intrusion of bureaucratic standards and diagnostic classifications into something that people had understood as, part of what it means. That now, interestingly, over the years since then, there hasn't been this rush of people being diagnosed with depression and bereavement. But I think what it said was that the public were a little bit wary about the overreach of psychiatry into sort of areas which we've always experienced as being part of what it is to be human.
Yeah, normal human behavior, I suppose. And that, you think like it's almost like if you've got the full range of human psychological situations, human behavior, from in fact, not a few, full range, and in the middle is normal, expected behavior, and on the extremes is, this is a problem, and it needs to be treated or handled in a different way. It seems to me like the scope of the width of what in the middle is normal and not able to be labeled is just getting really, really narrow, really narrow. So it's easy to stray outside of that and become someone who has a condition and has an issue. And, part of that has got to be driven by pharmaceutical industry. It's profitable. The more people who are perceived to be ill, in inverted commas, or ill, or have a medical condition, then the more money can be made, right? And the cynic in me thinks that is the main factor in what we're seeing at the moment. I think the main factor. We're quite lucky in the UK, I think, compared to, say, America. But I don't know how you control that. I don't know how we control that.
Well, it's a good question, and I think that there's a number of factors that have aligned in terms of this escalating rates of diagnoses that we're seeing. I've already sort of, if you like, criticized my profession a little bit by saying I think our guidelines often don't do a good enough job of differentiating between illness and normal variation. I think there is a cultural understanding of suffering in a mental health framework. So we do increasingly see people whose first thought is this a mental health problem? I think there's a certain looping effect, which is that the more diagnoses are talked about, I think you touched on it before, the more people have heard of it, there's greater awareness, and then people start to identify with the symptoms and wonder whether that could be them, like your adult ADHD example. I think that another factor, I think you would say, is that it aligns with pharmaceutical industry goals. I don't know the extent to which they're pushing it or not, and I've never been much one for, if you like, it's all big pharma or whatever. But you would have to notice that the number of antidepressants being prescribed, I think, and my figures might be slightly wrong, but I seem to recall in 2008, it was about 36 million antidepressant prescriptions in the UK. I think that was in one BMJ article.
36 million?
That was in 2008. I think by 2000 and...
In the UK?
In the UK, yeah. So it was, and then by 2018, so a decade later, it was just under 71 million prescriptions in the UK.
How many people are in the UK?
I would guess about 70 million. That's total number of people. I think the figures now are somewhere in the 80-something million from the NHS Business Services Authority.
I
as
don't
I
understand
recall.
how we can have that figure when there's only 70-odd million in the
Well, I
UK.
don't think I presume that's how many prescriptions are made each year, presume.
Okay. So it could be like the same person gets 3 or 4 a year.
Yeah.
Repeat prescription. Okay, I got it.
It doesn't include private prescriptions as far as I can tell.
Okay.
But the number of prescriptions are steadily increasing. We can see over the decade as the rates of depression or people being diagnosed with depression are being treated. And so it leads you, we can see the sort of very substantial increases in ADHD medications. Certainly there is, it aligns, let's say, this increased number of diagnoses. I don't know the extent to which it may or may not be driven. But I think there's enough other things to look at aside from the pharmaceutical industry.
Oh yeah, no,
Yeah,
I'm not.
yeah.
I mean, I would love to blame Big Pharma for everything, but it's just not the case. It's just not the case.
Yeah.
I say I'd love to because at least then you know where the problem would lie. You can fix it. Or all of the problem. But so, all right, question. In terms of these increased rates of diagnosis of the various things we've been talking about, are either men or women disproportionately represented there? Is it increasing more in one or the other for different things, or in general? Do you know?
I'm not sure the
You may
answer
not have
to
that
that.
information.
I think that increasingly women are being diagnosed with some of the neurodevelopmental disorders, and I think many
Adult women.
Yeah, and I presume children, although I don't exactly know, but I think a lot of the debate that if someone's opposite debating with me about that, I think they would say that this is a catch-up of people who should have had the diagnosis but didn't because it was under-recognized in women. So I think that might. I think it's probably across the board as well. I think there's a higher number. But in terms of the other diagnoses, I'm not sure whether there's a gender sort of difference in this increased rate in diagnoses. We can see the rate of diagnosis in depression has increased sort of in a population from somewhere around 5 or 6% or prevalence, if you like, to somewhere around 10%. There's very substantial increases.
Well,
in
200%, right?
It means very substantial increases in how many people are being diagnosed.
Can we talk about narcissism? We were talking before the podcast, and I read in the book, and I sort of chuckled away. And there was one of the things you said about the over labeling, and you see it on social media, and 5 signs you're living with a narcissist, or 5 signs your boss is a narcissist, or whatever.
Yeah.
And I chuckled away because I'd recently had a conversation with someone, and we both came to the conclusion that the person this person is having problems with is a effing narcissist, right? And I based that on my experience with someone who I believe to be an effing narcissist, right? And then I read your book, and then we were talking, and I thought, God damn it, am I wrong? And I'm convinced I'm not wrong. But has the definition... I think, on that subject, right, when you have a disagreement with someone, and you did make this point in the book, you're having a disagreement with someone, significant disagreement with someone, or there's this constant friction there with someone you have to deal with, it's nice to be able to think, they're the problem, and I can label it. I can label that problem. This is the problem. It's not always the case, and it's not always they're the problem, or not 100% of the problem.
Well,
sometimes you...
I used to see, when I was training, I spent for a few months as a trainee psychiatrist in a sort of relationships and sex clinic. And it was interesting when couples were arguing, he might say about her in many ways that she's wrong. And then when things are reconciled, that he might say, oh, she's being much more reasonable now. But as far as he's concerned, he was just his normal sweet self the whole time, and she has gone from being unreasonable to far more congenial, and they never saw that there was anything to do with them. It's interesting, the labels of personality. I once heard a definition of an alcoholic that sort of it makes me laugh. Obviously, it's untrue, But someone said the definition of an alcoholic was someone who you don't like who drinks more than you do, and and it stuck in my mind because I think that to some extent that's become a little bit about personality disorders in the common usage, which is it's often used as a little like psychiatric name calling, that there's something. It's always your ex that was the narcissist, or your boss that's a psychopath, or the whole area of personality disorders in psychiatry is a really difficult one, because we've recognized that people's personalities exist on a spectrum. You know, there's a whole range of feelings, emotions, behaviors you could have, and personality disorders sort of try and parcel up certain behaviors and say, well, if you've got this many of these kind of behaviors, then you have this personality disorder. Classifications now are moving away from that to what they call a dimensional system, where they say, well, we don't really label people anymore like that. We say that they've got this number of this traits and this number of that traits, but they're not, we're not labeling them anymore. Or there is an option to label them in some classifications, but it's interesting because narcissistic personality disorder is, still a diagnosable thing from the US classifications. But I have never seen someone come to me in clinic because of that. Almost self-evidently.
But a narcissist wouldn't, though.
They wouldn't say, I'm just too perfect.
No narcissist is self-presenting.
No, exactly.
I think I'm a narcissist.
Yes, and I need help.
You say, by definition, just present yourself and saying that you're not.
And it suggests a certain sort of humility, doesn't it? And and so there are sort of traits that help define it. But
go on, explain those traits to me. Well, and I think this is good, actually, because I think a lot of people maybe listen when you listen, and think, God damn it, I was wrong.
I would give the caveat that I'm not, I don't think I've ever diagnosed it. And certainly it's not something I've mugged up on, because it's not the sort of thing that clinically I find very useful. But I think there is something about this excessive self-regard, self-importance, often a disdain for people that are, quote, smaller than them, who they feel are not up to their level, a wish to associate with people who they think are important or valuable, wanting to see the number one doctor in this, and always wanting to sort of be associated. Some people say there is for some people, a sort of deep-seated vulnerability or insecurity, which means people can be very prickly and sensitive to how they're being addressed or spoken to. And, so sort of need to hear validation and praise a lot of themselves, which is how you sort of end up rubbing along with them. And also a certain sort of disregard for the feelings and emotions of other people in their lives, that they're seen really as sort of people that can play a role for them, rather than individuals with their own needs and feelings and that sort of thing. So those sort of things will broadly define, what it is to be a narcissist.
Yeah, I'm glad you're being careful with your words there, which I expected anyway. And the reason I'm saying it, because I was thinking, when you were listing off these things, and there's a whole, there's a range, and there's probably a bunch of other things, right? When I listed off these things, I was picturing someone going online and going, what's the definition of a narcissist? And like these bullet points, Google will do it. Yeah. It'll probably throw up throw up a bunch of bullet points that, bang, 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 bang. And usually when someone is asking that question, because they want to confirm what they think about the person they don't like. So they're gonna, they'll be listening to you potentially go through those things and going, oh yeah, that person ticks that box, tick that box. But in isolation, again, you will know this more than better than anyone. In isolation, those individual things mean nothing. Someone ticks one of those boxes, it does not mean narcissist.
It does not.
If someone ticked every single one of the boxes that you just talked about, it doesn't mean narcissist.
Right.
These are just like anecdotal, they're anecdotal indicators until an actual full-blown assessment is able to be done, which is rare on a narcissist, probably.
Correct.
But
I think that you're making an important point, which is, you see it on a lot of political figures or political leaders, and it has caused a certain amount of consternation, which is about labeling people with personality disorders from afar.
Trump's a narcissist.
So that
you can find that somewhere.
You see that written, and you think, well, how do you know, first of all? I've not sat down with Trump and had a conversation with him, and I don't know what he's actually like. And, what I know about Trump is what I've seen from his policies and his public pronouncements, and that's enough for me to decide whether or not I want to vote for him. His personal shortcomings, if you'd consider them that, are no secret. You can observe yourself whether he is the man for you or not, and you can vote for him or not, depending on whether you like what you see. But I don't feel that any labeling serves a value apart from name calling. And again, I talk about labels. I mean, presumably, I assume Trump wouldn't care what people are saying, but I think that labels are sticky labels. You label with someone, they're a narcissist, they're a psychopath, and it's, it carries a weight if you're a psychologist or psychiatrist saying it and saying it publicly. And so I am, I do have a natural sort of caution or even dislike of public figures being labeled in that way. I don't think it's very fair on them. And fundamentally, they're human beings too, doing a job that I think I would hate to do.
Yeah. And I mean, you can imagine, I'm not saying Trump is or is not a narcissist. I've got no idea. But you can imagine the kind of people in your profession who will go on to daytime TV or a news program, or whatever, and throw these diagnoses out when all they've done is watched the same news clip as everyone else watches. And I've done this analysis and throw out a diagnosis there. You can imagine what kind of people these must. What the quality of their diagnosis in their private practice, which they almost invariably will have, because they're doing that stuff on TV in this way that undermines the whole profession. And they're doing it to make money. The majority of it. I can't imagine ones that would not. And it's a disservice to the profession. And it's another thing, not just psychology. It's from physiological conditions and things like this. It's a problem. And it's a problem that the internet will lap it up.
Yeah.
The internet will lap it up, and also it's a misrepresentation of how diagnosis should be made.
Yeah, I think that's important. And I as I said to you earlier on, diagnoses are difficult. I think there's a perception it's easy, that you just need to have a couple of this and one of that.
Yeah.
Whereas actually it's like the example you gave earlier of that person with ADHD and autism, where it's a series of meetings of real scrutiny and triangulating the opinion from various things, and often after a consultation lasting an hour or so, I'm still not sure that I want to put a diagnostic label on someone. I have a natural caution, but you often hear, well, they told you they're depressed, so they must have depression. It's really not as straightforward as that. And I think fundamentally, personality disorders are one of those diagnoses that I think are often used as a form of name calling. There was, and I think that was part of the problem with personality disorders. I think to say someone's got a disordered personality is to really strike at the very root of their being. And so again, I really have to be sure of myself before I'd want to venture that diagnosis.
Yeah. And going back onto that topic of people coming in and wanting to get a diagnosis about something, it is so much easier to be able to deal with how difficult you are finding life if you can attribute it to something outside of your control. I think. And I think in the majority of cases, most cases, if someone is having finding life difficult, either long term or short term, I'm going to go out on a limb and say, in most cases, that situation can be changed by themselves, mainly through actions they could take, which would be difficult, decisions they should make and actions they could take, to change the circumstances. I really think that is the case. And it's certainly been the case for myself in the past in some circumstance where it'd be a lot easier for me to say, yeah, it's not my fault. This is just the way it is. And I can't do anything about it. And I'm a victim, I'm a victim of such and such circumstance.
Yeah.
But, and that goes back to another problem with another contributing factor maybe to the over diagnosis, victimhood and attributing blame to something else for your situation has just become like a normal behavior, looking outward first as opposed to inward. And also ties into the restriction that a label can place on you and what you think you can do or achieve in life, and your chances of being like, in inverted commas, successful or having a happy life. I've got this label now, which means I can't do X, Y, I shouldn't do X, Y, Z. Where in fact it should be, what can I do?
Yeah.
Not what do I think I can't do? Have I tried that? Can I do this?
Yeah, I think, I mean, it comes back to something that you touched on when we were
turn this heating down slightly.
Yeah, sure.
Keep talking.
What we were discussing before about locus of control, or we sort of touched on it.
My daughter mentioned that.
That's why.
Daughter mentioned that.
Well, that's why I thought you were coming to that.
No,
because you're sort of talking about it a little bit now.
Okay, so it could have been a nice smooth segue, but I didn't ping it.
Yeah. but that is this sense that you, by your own actions, can change your own outcome. That you're not sort of passive. Look, again, I'm not saying that some people are suffering. Some people are suffering with mental illness. They need treatment. Some people are suffering, and what they need is a different type of support, not to go down a mental illness label pathway. Some people might need help to see how they could do things on their own or their self-efficacy. But that locus of control really is important in feeling that what you can do can change your circumstances for the better, that you're not a helpless, passive sort of victim of circumstance and what everyone else is doing to you. And I think there is some evidence that people with this locus of control that's internal, which is to say they believe that they can change their circumstances, tend to do better. I think in school, and I would hazard a guess in life, it's a better way to be than to think that you're a helpless, sort of passive, sort of part of a system over which you have no control. And I think with that, you can start to blame lots of other people for why things are going wrong in your life. And that's never a healthy place to be, that it's, these people coming into our country, or it's this or it's that, it's not healthy to be always looking outwards for an explanation.
Yeah, I agree. But I want to come right out of say left field there. This is not mentioned in your book. It's just popped into my head as a consideration. I'm going to ask you on it. Do you think that the kind of state we live in from a welfare perspective, welfare state, the amount of provisions there are for people to help them find life easier, from financial benefits from the government to other such welfare oriented benefits. Do you think that is problematic where self-agency is concerned and this era of victimhood is concerned? Now, this is not a topic you would expect to talk about.
Sure.
I did not expect it to talk. It just popped in my mind. I was thinking, what factors does that play in that? And the reason I ask it is because I think when there are ways for, if I'm on hard times, if there are immediate ways where I can make my life easier, where I don't have to do anything other than access those ways to make my life easier, my consideration of the personal effort I should go in to improve my situation is less so.
Mm. Yeah, I don't really know what the answer to your question is. I mean, I think that the first thing that came to my mind when you were talking is that, you know, as a society, if you look at the rates of diagnosed mental illness, you say, for all the fact that we're a wealthier society than we were 100, 200 years ago, we've never been more unhappy or iller. I'm not sure what that's telling us. To your question about these sort of motivations of people, I think most people would rather be working, be in control of what they're doing, a sense of having accomplished and earned what they're doing. And I mean, I suppose, although I'd not expected to talk about this, I suppose
Sorry.
No, but I don't mind, because it's an interesting discussion, isn't it? But I think the worry for me might be, you hear it a lot about AI and people's jobs and where that's going to leave us as a society. Because I think people do need a sense of purpose in their lives. Any people's work gives them a social life. It gives them a goal, a purpose, a connection, a feeling of belonging. All of these things are really important to people in their lives. And I think people that don't have that sort of drift along, lacking this sense of what they're about or what they're for. I often see, sometimes see people like that. And again, they come to my clinic and it looks like depression. People unsure what they're about, what they're getting up for in the morning, what their goals are, lacking drive, motivation, purpose. And you can easily say, well, these superficially look like depression, but antidepressants isn't the answer. It comes back again to how we conceptualize things as a diagnosis. They might score highly on a tick box thing of what depression looks like. So I think the sort of social circumstances, I think, really do matter. I think agency and locus of control matter. How we go about inducing that, I'm not really sure. Why you personally have that and feel that you can do stuff and other people don't, that's a whole other question. Or could you learn to do it? If you don't have it already, I'm sure you can learn some aspects of it anyway. But I think those are really important sort of psychological aspects. Because when we talked before about an assessment, a psychiatric assessment is not just about why you're here now, although it'll obviously include that. But I ask a lot about people's personality, about their normal personality, the ways they understand, attribute, manage problems in their lives, their prevailing sort of moods and relationships and all of that, as well as their family and social background. And there's so much that you need to understand before you can really say anything meaningful about the reason they walk through the door.
Yeah, I know what you mean. And how much, and maybe, how much value do they put on personal responsibility? How much have they tried self-help before they presented? Maybe, because to me, that's an indicator of how serious they think the issue is. They're good questions that you are, and it's a good way you approach it. I knew you approach it like that from reading your book. You're very thorough in what you do, and it's really important. That context is really important. And one of the things I do if I have to go to a GP, or if I've been taking the kids to a GP in the past for issues, one of the first, I know very early on what I'm going to think about what this GP says. It's like, what are they asking about? Let's say depression, for example. And they go in and instead of, what are the first questions they're asking? what is your diet like? I feel depressed. What is your diet like? How much physical activity are you doing? All these other things, as opposed to how often do you feel sad? You know, on a scale of 1 to 10, have you ever considered suicide? You know, what are the other things, these contributory factors, which are things that within your sphere of influence, diet and activity, I think are two of the biggest ones. And often I've seen in the past, another, you know, and it's where these just aren't even considerations. And it goes back to the, like America, the big pharma thing over there, this immediate move to prescribe or diagnose in order to prescribe.
Yeah.
You know, when in actual fact, I'm at the point I'm making is I think most people's situations can be improved. Doesn't mean they haven't got a diagnosis or an issue, but most people's situation can be improved just through some personal agency. You know, and I think people, it's less and less important to people.
Yeah.
No, not because of their own fault, to do something, try doing something about it themselves. Because it takes effort. And quite often the filthy little secret you find is that the situation you're in, your mental situation you're in, is quite often, I'm going to limit to say, quite often, it doesn't mean mostly, but quite often, a product of your own doing. But it means you can fix it yourself.
Yeah.
Which is normally a really quick fix, as opposed to a costly and long fix, which you don't need a label for, maybe.
Yeah, and also increases your sense of self-efficacy. That's
self-efficacy?
Well, as in agency, we called it before, or locus of control, or all of those things. I think if you're fixing problems for yourself, maybe with the guidance of someone, I think it's better for you that you'll feel.
It's very empowering.
Empowering. That's exactly what I was reaching for. You know, and again, there are situations when you can't, where you need professional help, but there are those situations where someone telling you, look, I think this is what you can do for yourself, it is empowering.
Okay. We've still got a bunch of questions, sure. So if it's all right with you, I'm going to come on to some of the questions that were asked earlier that we didn't cover. Is that all right?
Yeah, of course, yeah.
All right. Shit. One just popped up right in front of me. I thought, okay, I'm going to ask that one because it amuses me. The question is, what do you think of Dr. Phil?
Dr. Phil, I'd never even watched Dr. Phil. I hadn't spotted
that earlier.
Don't even know who he is, unfortunately.
Yeah, Dr. Phil, he's off Dr. Phil's off daytime TV, is he not?
Well, I'm usually at work, unfortunately.
Oh, good. Okay, that's well avoided. Well avoided.
I feel like I have avoided something there.
Okay, question from Coke. Would you agree that there are cases of people who are physically healthy but have severe mental health issues where suicide is the best option for their suffering?
I mean, I wouldn't. I think if someone is having suicidal thoughts, I think they need professional help. And I can't think of. I mean, there's a question. I guess the question is there such a thing as a rational suicide?
Euthanasia, right?
Yeah, or something similar. I think nearly all people with suicidal thoughts or urges have some kind of mental disorder that they need to get help for.
Most, yeah, okay.
Yeah. And I mean, it's the thing that as a clinician, I perhaps worry about the most is a patient under my care who might go down that road. And I think it's it's an emotive and difficult topic, but no, I would encourage anyone, if they're having any thoughts like that, to get proper professional help.
Yeah, I totally agree. Totally agree. Okay. When have you suffered most, and how do you look back on that time?
That's a really good question.
If you don't mind.
No, I don't mind in the least. And I think it's a great question. I mean, me personally, I know that I have a higher capacity than average to worry about stuff. So as things, there's been sort of moments, periods of my life where I've just, perhaps like a lot of people, but I've, where I've just sort of been up at night endlessly worrying about if you imagine anxiety as a threat event, for a future potential threat. You worry about a whole load of adversities happening that haven't yet happened. I remember someone once heard describe their lives as a series of major disasters, none of which ever actually happened. And sometimes I live a little bit like that. And there's been moments, I'm not saying it's the worst thing ever, but my heart goes out to me a little bit when I think back to those moments. And one time I did speak to someone and I did find it helpful. I don't think I've ever said that out loud before, but if it helps people, I think there are times when you just want to have an objective view that helps sort of steady the ship a little bit.
I appreciate you sharing that. It leads me on to my own question, actually. We'll come back to the patient question in a minute, and that is, do you think that the I was going to say the over availability of a like being able to go and pay to speak to a psychiatrist or a psychologist, do you think that is a problem? I know that. So I'm pretty sure I'm saying that in America, for example, it is not uncommon for people just to pay to go and see a psychiatrist regularly, just because they get something from that. And I'm not saying it's a bad thing to get something from that, but it leads me to think that it means that they're missing something else in their life socially in some way, or from companionship perspective.
I hear the question. I mean, I feel that for the most part, the end result is that the person doesn't want or need to see you anymore. That's what I'm aiming for when someone comes to see me, is that 5 years later or a year later they've forgotten that they did, and 5 years later they can't even remember my name if they hear it. You want people to get something out of seeing you and be able to live and move on with their lives afterwards. So it's an interesting, I think, when you think of the Americans, they're often in sort of psychodynamic kind of therapy, or seeing a psychotherapist. And I say, well, if it's helping, then good. I often think then there should be an endpoint to it, where you've got what you can take out of it and move on and live your life. And for me, I think that's really important. Ultimately, all of us want the same thing for each other, which is to live fulfilled, happy lives to the extent that we're able to, and that's not sort of, affected by mental illness or.
Should the onus be on the psychologist or a psychiatrist to say, no, you don't need me anymore, bye?
I mean, I have had that conversation with people, and for the most part, people are pretty relieved to hear it, because they're getting an affirmation from someone who ought to know about this, that they are now ready, that they've got what they need out of it. Mm-hmm. I think when life or tragedy delivers you a blow, it can knock your confidence, and you're not quite sure at which point you're ready. And it's very easy to keep seeing someone in a month's time or 2 months' time. I think there comes a point when you have to say, I think you've come as far as I can take you, and I think you don't need to see me anymore.
Okay.
And most of the time, people have sort of realized that as well.
Mm-hmm. Mm-hmm. Okay, next question here from the patrons. Tough one. I say tough one. It's so are there people you'd refuse to help, such as rapists or pedophiles?
Goodness me. I don't know. I've never been in that position. I'm sure that there's sort of rules in terms of having to help people that come for help. I guess the question is that how do you sort of manage it emotionally and all of that as well? But it's never come up, and it's not really something I know how to answer.
Yeah, I think if I had the option, it would be a straight no, and it would be put them in the blender.
But I don't think, I don't, well, I think you probably wouldn't know at first, but I think people, we're a health service, not,
It is
Yeah.
the thing is, it's an interesting topic, but one that it's a road that you don't even want to venture down really, because being a rapist, we could argue being a serial rapist, certainly, being a paedophile, certainly. These are psychological conditions, right? These people are ill. It's like murderers. It's not a crime of murder. It isn't a crime of passion. When you go, okay, I can totally understand that. Like, for example, a father or a mother and their child gets raped, and then the father or the mother goes and kills the perpetrator. Like, you go, okay, yeah, I get it. I totally get that. But in a serial sexual violence perpetrator,
but
there's an illness there.
I mean, there are psychiatrists called forensic psychiatrists who sort of deal with that area of psychiatry's intersection with the law, and there are hospitals for people with mental disorders who commit crimes. So yeah, I just really don't think I can get any further with that.
No, it's fine. I didn't. I wasn't expecting to get any answer for you. It's just I was just making the points. Like my God, it's almost like, okay, you got to recognize that. You don't have to recognize, but you recognize that there is a psychological issue with these people, but also stuff them. There's a point where you go, oh, there's
it's very
anyway, lock them up, throw away the key, etc. Has a patient ever threatened you?
Thankfully not. I mean, I don't think you go through a career of 30 years without some difficult moments. But no, I've thankfully never been, and I'm not sure what circumstance that would be. I might have had difficult conversations, but then you're paid to have difficult conversations sometimes. People, you need to be having them at least when it's appropriate to. But no, thankfully, it's not ever come to that. But I wonder what the situation would be in which someone would want to do that.
You've what? Sorry?
I wonder the situation in which someone might want to threaten you about something.
Oh, you sit there and you diagnose them as being a narcissist. That's what it's about.
Yes, and insist on it. Yeah, maybe that.
And he's a 6'9" steroid abuser with multiple other issues. Anyway, okay, question from David. You've worked in psychiatry for a long time. What is one change you've been glad to see, and what is one change that concerns you in the field of psychiatry?
Yeah, I mean, I think when I think I sort of touched on before, but when in the 80s and 90s, when I was sort of training in medicine, I think stigma was really a problem. And I know that that's eased a bit. And I would say not for all diagnoses, by the way. I think there are some diagnoses that are still stigmatized. I think people, as we discussed, people wouldn't put on their Twitter profile that they got sort of paranoid personality disorder or whatever it might be. Or people are far more reluctant to put certain psychotic type of diagnoses. So, but generally speaking, I think stigma in psychiatry is reduced, and I think that is certainly for the good. I am, I suppose the concern I have is really what I've written No More Normal about, which is about the rise in psychiatric diagnoses and what it's doing to us as individuals and a society. And I think, in future diagnostic classifications, I would like to sort of see a hierarchy so that people aren't given 4 or 5 different labels, but there is one label into which the others are subsumed, to have a more sort of diagnostic clarity about certain labels as well, for labels to be used as they're meant to be used. I think we need to look at ourselves in psychiatry as well and ask, why has this happened?
Mm-hmm, mm-hmm. The comment there on people would not be, we put certain labels on their profiles, but the opposite is also true, right?
Mm.
And it's one thing that leads me always to make some judgments about people. It's like you judge a book by its cover sometimes, and you look at a profile on X or Instagram or pick the social platform, and in the bio is a diagnosis. Commonly you'll see on there autism, ADHD, PTSD is a big one.
Yeah.
And personally, I think it gives me a little insight into maybe what that person's like. A real general, I don't know, kind of specific. They go, okay. What I mean by that is, it means that for some reason they see it as important to tell people that is what they have. Yeah. And sometimes, or quite often, I think that is likely to be a limiting factor on the way they live their life or how they perceive themselves, which you touched on earlier on. Especially where it's things that can be overcome. I feel like PTSD is a diagnosis. I feel like PTSD actually, in cases, I think that it can be, I don't want to say cured, but I do think that state can disappear completely through just growing older. And your brain changes, or the way you perceive things, or what you learn, it just changes the way you perceive things. Because a lot of the way a PTSD diagnosis impacts you, all the way it comes about, I think, is through your perception of the past and how you deal with the past. Maybe. But on that topic, why do you think that people? It's quite common for people to do that now. Put these labels publicly.
Well, that's something that I've wondered, because when I was sort of growing up, so to speak, the whole anti-stigma campaign was that your diagnosis didn't define you, that you weren't a schizophrenic, you were a person who had schizophrenia, and so it's an old sort of inversion of this now, where it's the first thing people want you to know about them is a diagnosis. It's saying something, I think, culturally about where we are now, and I think that's just where we are in 2025. And the question I'm asking is, are we in the right place? Is this a good thing? Where we're always trying to sort of find that balance between, are we diagnosing enough people? Are we diagnosing too many? Where as society do we think this line should be? And I don't know. I just think that it's sort of a cultural phenomenon at the moment that that I think many of us have noticed.
I feel like I think it doesn't. I think it. There may be people who listen to this now, and they have this. They do this, and there are definitely people who listen to this and got PTSD and other conditions, right? And I think that you do need to disservice yourself if you do this. And the reason I say that is because you shouldn't want to give people the option to make a prejudgment on you, other than purely on what you do and what you say. I don't want to see these. I don't want to. One of the first things I find out about something who I'm later going to meet, for example, to be this label, this condition that they're being diagnosed with or they have. I don't want it, because I want to be able to judge someone purely on what they do and what they say. That's it. I don't want none of these influence factors. And you can say, well, just ignore that. You don't have to pay you can pay lip service to it. It's not that simple. Everything I learn about something goes into building a picture of what I think about them. So the less I know about their background or their mental condition or their physical condition before I actually meet them, in my opinion, the better. Whether that's a physical condition, physiological condition, blindness, for example, just the skin color, their religion. Unless it's a practical piece of information I need to know it's going to influence, for example, where I choose a restaurant, where we're going to meet, all of these things. I just don't want to know. So if you were presenting to the world voluntarily this thing that could be perceived to be negative or could be perceived by someone as, oh, you, this person who's got this label in their Instagram bio, that they could perceive that as a negative thing, you're doing a disservice, because people are going to judge you on something that is absolutely irrelevant. It's what you do and what you say that matters, right? In terms of how you should judge someone. I
absolutely agree. I think you take people as you find them, and but there may be, they are trying to tell you something in the bio, and maybe that they feel it is important for you to know, and how you relate to them, or what they advocate for in, on their social media feed. Maybe that's what it's about.
Okay, right. More questions here from David. Where are we? Okay. Do you think we as a society have become less able to cope with emotional pain and uncertainty, and that's part of why diagnoses are on the rise?
I don't know about less able to cope, but I think it's just a different understanding of where it's come from. I think we used to have sort of, I talked before about isolation, loneliness. I think we used to have sort of networks that we could ask for advice from, discuss problems with, get some lay advice about it. I think if you were in the 14th century, you might understand it very differently as a divine plan for you, or that's why you were suffering in some way. I think my feeling is that we've come to understand our suffering in our contemporary society very much in a mental health framework rather than anything else, and we feel that that's the pathway which we might need to go in to resolve the problems that we've got. So I suspect that we still got the same ability to resolve things, but we might lack that same network, that same understanding of what's going on. I think I don't know for sure, by the way, but that's how I would perceive it now.
Okay. Right, we've got a handful of questions left. What is the hardest, this is from Coke, what is the hardest mental health issue for someone to have and to be treated, in your opinion? Like, if you had to pick one, what is the toughest thing?
I think it's really difficult. I think, I don't know if there's one thing. I think people suffer in all sorts of different ways. And I really don't think I could pick one. I mean, the people with psychoses, I think, are suffering, but then suffering is suffering, whichever you are. I don't know. I'm not sure how to answer that, because the individuals perceive it as they perceive it. I've often thought very severe depression, that unrelenting bleakness. I think that I wouldn't wish anything on anyone, but as these things go, I think that must be a real torment.
Yeah. I don't understand how people keep going. I don't understand how people keep going.
I've been, we've talked a lot about
without help. I mean,
we've talked a lot about some of the stuff at the sort of milder ends and how to understand and conceptualize them. But I've seen some people at the more severe ends as well, as you'd expect, where I'm really quite moved by how they just kept one foot in front of the other, and kept the show on the road.
Yeah, that's an interesting point, actually. I think you get, if you've got something where you've got an absolute responsibility and you can't get away from it, it doesn't matter how miserably life goes. But if this sense of responsibility goes far and above your own needs, and I think people can keep going through the most incredible adversity. And one of the really common examples to give of that is a single parent, like not just a single, but a single parent who got multiple children,
Mm.
has not got the co-parent to lean on, to even share the responsibilities of parenting, and has no social life, has no money, has no ability to do anything of any pleasure or joy in their life whatsoever, but they've got children to raise. And so that and that overriding sense of responsibility to the children, and it's commonly, these situations are commonly more with women, because they tend to be the people who are end up with the children to parent them. And I think, my God, how many parents like this, and there's men as well, how many parents like this have the most horrendous lives, mental state, just nothing in their lives of joy apart from the children. But that's just necessity. It's literally just evolutionary biology and psychology driving them forward.
Yeah.
I
think people often do lead lives of real suffering and hardship. And it came back, we talked about this earlier, about the extent to which you need to be failing in domains of your social life to be said to have a disorder. We talked, and you made the point, and I think you were correct to say it, that people can be suffering with mental illness and have to keep the show on the road. And, just to keep going, keep income coming in, keep their clothes fed, keep the kids fed and clothed and everything. I think if you ask them, you'd say, they're clearly suffering with it, and they're not doing it in the way that they feel that they could be or should be, and they're not, and maybe their co-workers would notice that there was something of them that wasn't their normal selves. But I think people lead really difficult lives of adversity, suffering, and I would say, on that point, some patients I've met have been quite inspirational in their ability and their lack of sort of, if you like, lack of self-pity in how they've kept on.
I had another question here. So I had a guest on. I've had a guest on a couple of times. Guy called Ben Griffin, ex-special forces guy, diagnosed with PTSD, and he said on the podcast, I think it was the last time I interviewed him, I think he said then that he went when he went to seek help initially. One of the things that he had said was helping him was alcohol to deal with the situation, and apparently the counsellor he was seeing said, "Well, if it's helping, keep doing it." No, I am skeptical. He did say this. I'm like, are you misremembering that? But he's a good guy. What do you think about that advice?
Well, I mean,
is there a situation where that would be the advice? I can't imagine.
It's hard, isn't it? I mean, I wasn't there, and I don't know the consultation.
Unless you're chemically dependent on it.
But I think that alcohol, in the short term, in helps people, and in the longer term, nearly always doesn't. I think as a treatment strategy, I sense that could be asking for trouble, and I hope that. I mean, who knows who said what to who in a particular consultation? But it's.
The only situation is, like, I think if the counsellor was worried it was a chemical dependence, if this person was drinking 24/7, you wouldn't say, stop. That's not good for you, because you may not survive. Anyway, okay. So if someone wanted to find a therapist to see regularly, how should they start, and what should they look for?
I generally speaking, the therapists have I mean, it's not really my thing. I mean, the first thing is maybe your GP would be able to recommend someone. I think a recommendation is very helpful. There is a council, and I've forgotten what it's called. I think it might be the BABCP or something, where there's sort of registered therapists. I'm not exactly sure how to answer that. I don't want to give someone misinformation, but I think a recommendation from someone who ought to know about these things. So I work with a certain number of therapists who I'd feel happy to recommend. But there is a registration for them, and I think or a GP might be able to give you the right recommendations.
GP first stop every time?
Depends what for. But in terms of, I mean, the GP might have sort of counsellors within the practice And there's this access to psychological therapies, IAPT, which is usually fairly accessible within localities as well. So, it might not always have to be a paying option. There might be an option just to self-refer or to go via the GP to get help.
Okay. Right. Last question. What books, apps, or other resources, what online resources and others would you recommend for people who want to learn more about mental health, mental issues, or understand what they're going through and whether they should be concerned? But on that, you should buy Alice's book. I'm not kidding, one of the most informative books I've read. Really good, very balanced.
Thanks so much.
Highly recommend. No More Normal. Apart from that, what else?
Apart from that, I think the Royal College of Psychiatrists have a pretty good website with lots of public information and public information leaflets. And I think that would be a pretty good place to start, I would say, because you know that the information there is sort of validated and, sound. And so I think that's probably a decent starting point. Okay.
It's been a pleasure, Alastair. It's been a real pleasure. Is there anything we've not covered that you wanted to cover?
I don't think so. That was a really interesting discussion, and it sort of stretched me once or twice, which I would say is a good thing.
Okay, I'm glad to hear. We did dot about a few. My fault, but
no. I really enjoyed talking to you, and I hope your viewers, listeners, find it informative too.
Yeah, I think they will. Difficult topics. That's a difficult topic. They are. It's like anything these days. Not unlike anything. It's like a lot of things these days. There's subjects you think you're not allowed to discuss them, but they are a concern of people's. Yeah. For example, overdiagnosis. In fact, there was one more question.
Go on.
Okay, so this is my dear old dad.
Yes.
Who rang me when I said you come on. He rang me, and then he was ranting down the phone like, I said, stop. What's the question? His question was, or is, how do we fix it? So if overdiagnosis is the problem, if misdiagnosis is more, because misdiagnosis is always going to happen, right? If it is a more of a problem it is now than it has been previously, what do we do to fix it?
Well, I think, again, there's a number of sort of avenues for it. I think one is the classification systems. I talked about that before. I think we need to be a little clearer. I think sometimes we might need to put the justification for why a diagnosis is in there and on what evidence. I think that, a hierarchy of symptoms, so you can't be diagnosed with 4 or 5 things, but a single thing that would cover the other symptoms. I think there is maybe a sort of a conversation to be had like we're having now, where we ask ourselves, is this going in the right direction? Is everything that looks like this actually a diagnosable mental illness? And if not, where should we go with it? I think there's, I sort of talk a little bit in the book about whether, sort of quote, science will save us, whether we'll be able to have more sophisticated ways of imaging the brain so that we can say more about diagnoses, whether our sort of large language models and aggregation of symptoms will lead to different diagnostic categories that make more sense. I think all of these, so there's some things now, some for the future, but I also think maybe for an acknowledgement that even if we don't diagnose people are suffering and need help. And it might be the sorts of things only governments can do. And it might be something that they can do for themselves or that we can do, the sort of social prescribing of
the community
walks in nature, etc. And I think the final thing that I never mentioned throughout this, but I think is an issue, which is that often diagnoses are used as a means of sort of navigating systems like, adaptations at school, in the workplace, and that sort of thing, where someone has to have a diagnosis, otherwise nothing really will happen in terms of workplace accommodation. So we almost force people into getting diagnoses.
That is a great point. That is a great point. Yeah.
Yeah.
That is a great point because, as you know, the education system, the way we teach children, it doesn't suit all children. Suits most, and probably some very minor provisions could be made, which wouldn't be very costly in in schools or in colleges or even in universities, which would make the likelihood of academic success much higher.
Yeah. And the need to sort of justify why you need certain adaptations, that would sort of melt away, you would hope.
Yeah. Been a pleasure. You've got a website, alastairsanthouse.com.
That's it, yeah.
Okay, I'll put the link into the blurb to this.
Sure.
And is there anywhere else you want to point people?
Well, they can get my books from Amazon. This is the second of them. The first is on the interaction between mind and body, called Head First.
I will read that. I'll read that after I finish.
So I'm also narrating it if you're an audio person.
You're narrating it?
Yeah, I narrate. You probably recognise I narrated the book you've just listened to.
Yeah.
Yeah. So
I thought that was you. Yeah.
So I did the first one as well.
Okay, good.
Yeah.
Excellent. It's much better when the person... excellent. And one, if people want to contact you directly, are you available on social media, LinkedIn?
I'm on X, and that's pretty well the only sort of social media outlook that I've got.
So no TikTok dances, no Instagram reel dances.
No one wants to see me dance, honestly.
Listen, good luck with it. Thanks again for writing that book. Hugely informative, very useful. And anytime you want to come back to the studio, let's do it.
Oh, that's great. Thanks so much for having me.
No problem.
All the best.
Thanks.